So just a quick look at a case where we've done the whole body MR to look at the entire metastatic burden. She's a 61-year-old lady with lung cancer and neck lymphadenopathy. And when we do the MR, what we see is that's the STIR whole body image, and you've seen a lot of images. So my emphasis in this talk is not really so much on the images, but really the clinical need of it and the importance that whole body MR should be utilized for this application. So what you're seeing in these images is that's the primary mass lesion in the right upper lobe with mediastinal lymph nodes which are enlarged, another nodule in the left lung. You can also see in this whole body image that there are tiny nodules in the liver and a lot of bony metastasis. And this flare axial image shows a little hyperintensity there in the cerebellum and there in the parietal region. And when we do contrast imaging, sure enough, these are ring-enhancing metastases. That's the T1 vibe, and you can see multiple liver metastasis, and that's the depiction of the vertebral metastasis so well. So what it does is basically tells you what is the metastatic burden and what you need to do about it. So the patient undergoes chemotherapy as well as whole brain radiotherapy because we did detect very tiny brain metastasis. She responded initially and then she failed. There was disease progression and eventual death. The other clinical indication or need where you don't have to, but you could be using some form of imaging to look at the metastatic burden is in the follow-up setting. Now the follow-up setting, there will be two clinical situations where you would want to image them. One is to monitor response to therapy, and I must say here that CT PET has been accepted today to monitor response to therapy as far as lymphoma goes. For a lot of other carcinomas, there's still a lot of ongoing research happening. The other clinical situation in the follow-up setting where you would want to image is when the patient is symptomatic, because if the patient is asymptomatic, has completed the first line of treatment and is regularly following up with you, you actually only need to do a clinical examination. And you tend to image these patients only when the patients are symptomatic. The point is, you don't want to detect asymptomatic metastasis and increase the anxiety because it doesn't really impact too much as far as survival goes. But that's one side of it. The other side of looking at detection of asymptomatic metastasis is that when you detect it in certain body areas, for instance in the brain or the spine, you could act upon it. So if you detect asymptomatic brain metastasis, you would subject this patient to a whole brain radiotherapy so that there is no further morbidity by these metastases. And also, if you look at the clinical drug trials that have been happening, there are a fair subset of patients who are asymptomatic for their metastasis and who are receiving neoadjuvant chemotherapy and they are benefiting. So is it really true that asymptomatic metastasis should not be treated? That's a question of debate. Also, in the follow-up setting, you often tend to have patients who are marginally symptomatic and you don't know what to do. Let me give you an example here. If you have a patient, say with breast cancer, who comes back to you, who's finished the first line of treatment and comes back to you with, say, a backache. Now, this could be because of degenerative spine or it could be because of vertebral metastasis. If you had a tool which was non-radiating, which was going to depict to you whether this was metastatic or whether this was because of degenerative disc disease, wouldn't it be wonderful? And MR really gives you that answer. It not only tells you what is the metastatic burden, but also gives you alternate diagnosis. Having done the clinical situations where you want to cover the metastasis workup for patients, now I'll move on to the study that we did at our institute, and this is essentially a study that's been done for patients with breast cancer. It's a pilot study, so there is no randomization of the patients into any arms. The study was basically done to determine the utility of a comprehensive whole body MR protocol for metastasis workup in patients with breast cancer and breast cancer alone. We had a total of 99 patients from May 2005 to September 2009. And this was a retrospective analysis of the data, so it wasn't a prospective study. What the patients had was, some patients had their MR done at their initial workup and some during the follow-up. We had a total of 99 patients, but 114 studies because some patients had MR done more than once. 30 of these 99 patients had their MR done for TNM staging. And when a patient underwent an MR more than once, it was the first study that was used to classify them into negative for metastasis or positive for metastasis subgroup. We didn't compare it to any other imaging tool, but what we did was we followed up these patients, and we have a follow-up as long as nearly 5 years on these patients. What I'm presenting to you is the data as it was analyzed mid-April 2010. So that's the follow-up that we have on these patients, and we used clinical follow-up and imaging as indicated during the follow-up of these patients to corroborate our MR findings. So for instance, if the patient was called non-metastatic on the whole body MR and the patient continued to be disease-free, that was used as a verification of the MR findings. We had a follow-up, a median follow-up of 15.75 months, ranging from 0.5 to 57 months, and there were no mandatory comparisons with the simultaneous alternate imaging modality or pathological confirmation of the MR findings. This was our protocol, and as you can see, this is a rather extensive protocol that had its plus points as well as negative points. What we did was we at least had one good sequence for every organ, and then we combined it with post-contrast imaging that included a dynamic multi-phase imaging of the liver and a fat-saturated post-contrast imaging of rest of the body. We realized early on in our experience with the MR that we were missing out and not performing very well for sub-centimeter lung nodules, so we started to combine a plain helical CT acquisition of the chest along with the MR protocol, particularly when we were doing the workup for TNM staging, because that's where you want to be 100% accurate in your metastatic workup. Just an example to show you not what we have found. This is bone metastasis in a patient with breast cancer, but to tell you that these are high resolution images that would give any radiologist confidence to characterize the metastasis, and I don't think you could get better information on any other imaging tool. Of the 99 patients, 47 were positive for metastasis and 52 were negative for metastasis. Of the 52 that were negative for metastasis, 46 patients were disease-free at a median follow-up of 21.75 months, while 5 patients subsequently became metastatic and 1 patient was lost to follow-up. This was the disease course in the 5 patients who recurred subsequently or became metastatic, and as you can see in this chart, the time interval from the initial staging or doing the MR for TNM staging to the time where the patient became metastatic is fairly long. So this is not a failure of the modality, but this is disease progression. Of the 47 patients who were positive for metastasis, 35 were dead due to their metastatic disease at a median time of 4 months. Now, you would probably raise a question about the median time, the short median time of 4 months here. I must say that there was a little clinical bias in inclusion of patients in the study. So, for instance, a patient who was who came in with locally advanced breast cancer, and we did think that they were clinically too advanced a disease, they would have a high metastatic burden. We did end up using MR to look at the metastatic burden in these patients, and that's the reason why there were so many patients who were dead at a very short interval time from their initial performance of the MR. 2 patients of these total 47 patients have disease progression despite treatment, while 10 have their disease under control with appropriate therapy at a median follow-up of 17.5 months. These were the various sites of metastasis that we detected.